Well, welcome to this short series of multiple choice questions on the subject of pain. So what do you know about this subject? And as we go through, we'll be asking questions, but then we'll be answering the questions. And as we answer the questions, we'll give some information which is relevant to the clinical environment, because we need to reduce the amounts of pain our patients suffer from, and wherever possible, we need to prevent the pain occurring in the first place. Well, you know that sometimes when you hurt yourself, you get the pain straight away, and it's a sharp pain, and you can localise it very well. You know exactly where the pin is stuck into you or whatever it is. So it gets there fast to the brain quickly, and it's a sharp pain, and it's a well localised pain. That's what we call fast pain. The converse of fast pain is sometimes called slow pain. And this can take longer to get to the brain. So, for example, I don't know if you've ever got in a bath and it's too hot, and you think, oh, this is all right, I'll sit down. Then all of a sudden you realise, about a second later, or 2 seconds later even, that it's too hot and you have to jump out again. That's slow pain. And the thing about slow pain is slow pain transmits achy feelings. It is the distress and unpleasantness associated with pain. It's still pain, but it's not as well localised, it's achy and it's more diffuse. And there is a physiological basis between these two types of pain, the fast pain and the slow pain. So this question is asking you, what neurological anatomical structures are transmitting the fast pain from the periphery into the central nervous system? Now, when we're talking about the peripheral nervous system, we can talk about afferent and efferent pathways. Now, an afferent pathway is one which goes in from the periphery to the central nervous system. An efferent pathway is one that takes information from the central nervous system and sends it out into the periphery. Therefore, sensory neurons are going to be afferent, and motor neurons are going to be efferent. So we can straight away eliminate options C and D here because they're both motor neurons. These are both efferent pathways, but the pain is going from the periphery into the central nervous system. Now, the unmyelinated sensory neurons are the C fibres, and these transmit that slow, achy pain I was talking about. The pain is diffuse, it's hard to localise to a particular type of the body. You might just know it's in an area. So that's transmitted by unmyelinated C fibres. And the thing about unmyelinated C fibres is they're quite thin, and that means the impulse is transmitted more slowly because the axons are thin. But also they're unmyelinated. That's why the impulse is transmitted slowly. Whereas the myelinated sensory neurons, in this case, the pain is transmitted via A fibres called A delta fibres. These are myelinated, and when fibres are myelinated, they have these Schwann cells wrapping around them, and they have these neurofibril nodes of Ranvier in between the cells, and the impulse is able to bounce from one node to the next. That's a process called saltatory transmission, and it's much more rapid than the transmission that occurs in unmyelinated fibres. And also, when it gets to the brain in the fast fibres, the brain is able to localise to a very precise part of the body where the tissue is being damaged or is about to be damaged. So the answer there is that the fast pain is transmitted by the myelinated sensory neurons. Now, there's two ways that the brain communicates with the body and the body communicates with the brain, and only these two. The first is that the communication takes place between the 31 pairs of spinal nerves that go via the spinal cord. The second is that the communication takes place between the 12 pairs of cranial nerves. And a cranial nerve is a brain which goes to or from the brain directly without going via the spinal cord. And this is talking about sensory neurons from the body entering the spinal cord. So how do these sensory neurons, bringing information from the body that are communicating via the 31 pairs of spinal nerves, how do they enter the spinal cord, via which nerve route? Now, the central aqueduct is a passageway within the brain that allows the free flow of cerebrospinal fluid. So it's not that. The medulla oblongata is the lowest part of the brain stem. The brain stem is in 3 sections: the midbrain at the top, then the pons in the middle, and then the medulla oblongata at the base of the brain. And there are cranial nerves communicate with the medulla oblongata, but these ones that we're talking about here, it specifically says in the question, via the spinal cord. Now, all the sensory neurons that communicate with the spinal cord go in the back of the spinal cord. It's always a rear entry into the spinal cord. Whereas the motor neurons always go out the front. So it's always in the back, out the front, in the back, out the front. So the afferent sensory fibres always go into the spinal cord from behind, whereas the motor efferent fibres always leave the spinal cord from the front. And the horns are those pointed bits of grey matter within the spinal cord. So the anterior horns are at the front of the spinal cord, the posterior horns are at the back of the spinal cord, these areas of grey matter, and sensory neurons always enter via the back, so they always enter via the posterior horns. So pain neurons, like the other sensory neurons, always enter via the posterior horns of the spinal cord, from where the information can go up the spinal cord towards the brain. So we know that these pain pathways have to go from the periphery to the spinal cord and up to the brain. And many pain pathways travel from the periphery to the brain, as we've said, via the spinal cord, but via which tracks or which sort of matter are they travelling? From the spinal cord, the level at the spinal cord from where the nerve roots enter. How does that information get from that level of the spinal cord up to the brain? Now, the periaqueduct or grey matter is grey matter. That means it's mostly nerve cell bodies around about this aqueduct that we talked about that carries the cerebrospinal fluid through the brain. And the periaqueduct or grey matter uses endorphins as its chemical transmitter. And endorphins are the body's natural pain-killing chemicals. They are analgesic chemicals. And when we give opiates, so for example when we give morphine, diamorphine, codeine, when we give any of those medications, they're working by stimulating the body's own endorphin receptors. So this periaqueduct or grey matter will be activated when we want to reduce the amount of pain. And that information will go down the spinal cord in the dorsolateral tracts. Now, the dorsal surface is the back. So that means these tracts are towards the back, and lateral means the side. So we see that these tracts go down the spinal cord at the side, at the back, the dorsolateral tracts. And the combination of the impulse coming from the periaqueduct or grey matter going down the dorsolateral tracts will inhibit the afferent pain pathways. That is, it will inhibit the amount of pain impulses going into the spinal cord. It's a natural analgesic system. So that's not the answer to this question. Now, when an impulse from a nociceptor comes into the spinal cord, it needs to go up the spinal cord to the brain, to the thalamus, because the thalamus is the part of the brain that actually generates the pain. So the thalamus is the part of the brain that generates the pain. And the thalamus will generate a new pain when this impulse from a nociceptor comes up and into the thalamus. So what that means is the ascending pain signals have to go up a tract from the spinal cord to the thalamus. These individual nerve fibres will go up this bundle of nerve fibres called a tract. And because it goes from the spinal cord to the thalamus, it's called the spinothalamic tracts. And it's tracts because there's one on either side, of course, because you have two thalamic nuclei in the brain, the right and the left. Phantom is a ghost. It's something that's not there, isn't it? But phantom pain is a well-recognised medical term. What does it mean? Well, pain which is referred is simply called a referred pain. And a referred pain is a pain which is felt in a different part of the body to where it is generated. So, for example, you might feel a pain in the right scapula that comes from the gallbladder. Or you might feel a pain in the left arm that comes from the myocardium. So it's not that. Pain which is of psychological origin is a psychogenic pain, and it's not that either. Pain which promotes immobilisation, well, that's often good to promote immobilisation to encourage the healing process. But that's not what a phantom pain is. A phantom pain is a pain from part of the body which has been amputated or otherwise removed. So if someone's had their left foot amputated and they still get a pain in their left foot, that is a phantom pain. And the reason that this can occur is that when you actually feel something in your left foot, you're not feeling it in your left foot, you're feeling it in your right sensory cortex. The body is represented in the sensory cortex in a series of structures called the homunculus, the little man or the little woman that's inside the brain. So when your left foot is amputated, your left foot is still present in this sensory homunculus and therefore tragically can still experience pain. Well, if you're working progressively through this quiz, I think you'll be able to answer this question. So referred pain is a pain which is experienced in part of the body other than where the pain originated. So, for example, you might have compression of one of the lumbar nerve roots, but that pain is actually felt down through the buttock and into the leg. That's called sciatica. Or someone might be developing appendicitis, so the appendix is in the right iliac fossa, and yet that pain is initially felt perhaps just underneath the umbilicus. Now, why is this? Why are pains not always well localised in the body? Sometimes they are, but other times they're not. Well, sometimes there are two sensory neurons sharing a single ascending tract in the spinal cord. So when that impulse gets to the brain doesn't know which of the sensory neurons it was from because it's come up a single tract. And there's also a phenomenon called embryonic cleavage. So sometimes the pain is felt where that structure was when you were an embryo. And the brain still seems to think that that structure is where it was when the nerve connections were first formed to that structure. Other times, as was mentioned, there could be compression of a nerve which is felt down the pain is felt down the root of that nerve. So the key thing about referred pains is they're in a different part of the body, but they are often consistently in a different part of the body. So as we learn to recognise different conditions, we can learn to recognise the characteristic locations and characteristic features of referred pain, and that can help us identify what's wrong with our patients, sometimes very accurately. Well, the characteristic features of inflammation are well known. They are heat, pain, redness, swelling, and loss of function. But why is it that inflammation causes pain? When an area is inflamed, there's normally more white blood cells in that area, and there will be an increased blood supply in an inflamed tissue. And there should not normally be an increase in the amount of lactic acid. Increases in lactic acid occur as a result of anaerobic metabolism. But inflammatory pain, there is localized sensitization of nociceptors. So the nociceptors in non-inflamed tissue will depolarize, that is, generate a new nerve impulse, only when the tissues are being damaged. And they'll generate a new nerve impulse when they depolarize. But if there's inflammatory mediators around, that will lower the depolarization threshold of the nociceptor, making it easier for the nociceptor to generate a new nerve impulse that can go off to the brain and be interpreted as pain. So when tissues are damaged, the damaged tissues will release inflammatory mediators. So mast cells, for example, can release histamine. Prostaglandins can be formed from damaged cell membranes. And it's these inflammatory mediators that will lower the depolarization threshold of the nociceptors, therefore sensitizing the nociceptors, therefore making them generate pain impulses much more readily. That is why there is an increase in pain in inflamed areas in the body. In our day-to-day work, we come across many types of pain, and one of the pains we come across is colic. So, colicky pain is describing what? Colic describes pain from a hollow organ or a hollow structure. So, for example, we can get pain from the bile ducts, biliary colic, or we can get pain in the ureters, ureteric colic, or we can get colicky pains in the gastrointestinal tract because it's a hollow structure. So before an episode of diarrhea, for example, you might get colicky pains as there's contraction of the colon, propelling material down into the rectum prior to defecation. So what's actually happening here is that the smooth muscle in the wall of a structure will contract. It will squeeze down. Sometimes it will spasm, it will shut down forcefully. And going through the muscle, there's the blood vessels. So as the muscle contracts, that's going to squeeze shut the blood vessels. And if you're squeezing shut the blood vessels, the blood is not going to get to the area, therefore the oxygen is not going to get to the metabolizing smooth muscle in the wall of the structure. And this means that the metabolism will change from aerobic to anaerobic metabolism. Now that's okay, it can carry on generating energy for a period of time, but the problem with anaerobic metabolism is it will produce lactic acid as a waste product. So the lactic acid will accumulate in the tissue, and it's the acidic environment that stimulates the nociceptors, giving rise to this spasmy, colicky type pain. So remember that colic is just describing pain from a hollow structure, but it's crampy, spasmodic pain, and it can be very, very severe. So if a patient's admitted with ureteric colic or biliary colic, give that patient whatever analgesics they need straight away. They are in absolute agony from those colics. So we become aware of all tactility because of this process of transduction. There's an external sensory stimulus on the body, and the peripheral nerves somehow transmit that external tactile stimulus into the appropriate sequence of neuronal depolarizations that the brain interprets as the tactile stimulus. And pain, of course, is a tactile stimulus. So which of the following is true of peripheral pain receptors? So thinking about the peripheral pain receptors, the site of transduction of the pain impulse. To say they always transmit the pain stimulus via a motor neuron is ridiculous. Motor neurons are efferent, they are carrying impulses from the central nervous system out. And they are not referred to as Purkinje receptors. Now Purkinje cells, or Purkinje cells, it's a Czech name, it's named after Jan Purkinje, and I'm sure I'm pronouncing his name incorrectly. but they're very finely branching fibres. So for example, you get Purkinje cells in the cerebellum of the brain that are stimulated by this chemical transmitter GABA. And you also get Purkinje fibres in the myocardium, taking the impulse from the bundle branches into the myocardium, these finely branching fibres. So it's not that. And to say they're found in the central nervous system is also ridiculous because they're peripheral. Central is the converse of peripheral. And as I'm sure you already know, they are referred to as nociceptors. The noci part comes from a Latin word which means to injure. So they are kind of the detectors of injury. But we now know that they detect more than that. They detect any noxious stimulus. Now, clinically, it's often very useful to distinguish between acute pain and chronic pain. So which of the following is a characteristic of acute pain? Choose one answer. Now, acute pain occurs in response to tissue damage. And the converse of acute pain is chronic pain. Now, acute pain is very important to warners of tissue damage. People that can't feel pain are likely to damage their tissues. So you might think about someone with leprosy or Hansen's disease, where they lose sensation, or someone with diabetes peripheral sensory neuropathy, where they damage their peripheries because they don't feel the pain. So acute pain is good and useful, but chronic pain is pain that serves no function. And it has a destructive effect on the individual. It persists for more than 3 months. So pain which is normally caused by progressive pathology, that can be progressive ongoing pain because the pathology is progressive and ongoing. For example, someone with arterial leg ulcers. Pain normally persists for several weeks. Well, that's not normally a characteristic of acute pain. Although technically it doesn't become chronic pain till it's been there for 3 months, but that's somewhat of an arbitrary cut-off really. Pain is normally generated by touch dermal receptors. Well, no, they generate touch. So with acute pain, pain usually resolves when the cause is removed. But the risk with acute pain is it can become chronic pain. So a big part of the reason that we need to treat acute pain is because if we treat acute pain and get the acute pain under control, that pain is less likely to progress onto a chronic pain. So 2 really good reasons for treating acute pain. One is it's the humane thing to do at the time, but the second one is it can prevent the development of chronic pain. Nociceptic pain comes from the nociceptors. And how sensitive a particular tissue is to pain depends on how many nociceptors that tissue contains. So, for example, the pleural membranes around about the lungs are very rich in nociceptors. That's why patients get a lot of pain when they have chest strains, because of the high density of nociceptors in the pleural membranes. But this one relates to the skin. So pain from the skin derives from where precisely? The epidermis actually doesn't contain any pain receptors. So the epidermis, the top layer of the skin, is not actually sensitive to pain. So if the epidermis and the dermis are separated, for example, by some fluid and you have a blister, it's possible to remove the epidermis from the top of that blister, if it's appropriate to do so, without the person feeling any pain. It'll be very sensitive underneath, where the dermis, the dermal nociceptors are exposed, because that's where the nociceptors are. The pain derives from the dermis, not the epidermis. Now, the hypodermis is the layer underneath the skin, and it largely consists of adipose tissue, and that contains very few pain receptors. That's why if someone has full thickness burns and all of the dermis is burnt away, they might not feel pain in that area of full thickness injury. Now, round about it, where the injury is partial thickness, there can be extreme, very extreme pain. But actually the hypodermis doesn't really contain much in the way of pain receptors. And the muscle fascia below, well, muscles are actually very well perfused with pain receptors, but of course they're not part of the skin. So the answer is A, it's the dermis that contains the vast majority of the peripheral sensory receptors for tactility derived from the skin. There's actually a few light touch receptors in the epidermis, but there are no pain receptors. They are all, in terms of the skin, in the dermis. Now, in the nerve fibres, the pain impulse is transmitted electrically, but that pain impulse has to get across the synaptic gaps. And the only way an impulse is going to get across the synaptic gap is via chemical transmitter substances. And when we understand the chemical transmitter substances and the receptors that they bind into, that gives us opportunity for pharmacological interventions. We can give agonists, which will mimic the effect of a chemical transmitter, or we can give antagonists, which will inhibit the effect of a chemical transmitter. So which of the following chemical transmitters are found in ascending pain pathways in the spinal cord? Now, there's two main chemical transmitters transmit pain from the peripheral nerves through the dorsal horn of the spinal cord into the ascending pathways. And they are glutamate or glutamic acid, it's the same thing. And the other one is substance P. Now, the fast pain from the A delta fibres is usually transmitted with glutamate as the chemical transmitter. The slow pain transmitted by C fibres, very often the chemical transmitter there is substance P. So the correct answer here is glutamate. Noradrenaline or norepinephrine, it's the same thing, is a chemical transmitter associated largely with the sympathetic nervous system. Acetylcholine is a chemical transmitter associated with the parasympathetic nervous system. And endorphin is the body's natural opiate type molecule of chemical transmitter, which is involved in pain inhibitory pathways. Well, this is the last question in this series. So which of the following chemical transmitters is associated with analgesic pathways? And I think I might have just given you the answer to that one, so make sure you get this one right. So as we've recently answered, it's endorphins, which are the chemical transmitter in many of the body's analgesic systems. And opiates will enhance this endorphin effect. Opiates are endorphin agonists. They work in the same way and will stimulate the body's natural analgesic pathways. Well, here is your opportunity to be honest with the world. Do leave your score out of 12 in the comments section below. Give me some feedback. It's always nice to know that there are human beings out there listening to these recordings.